going to introduce Grand Rounds. I'm Howard Chansky. I'm the chair of the Department of Orthopedic Surgery and Sports Medicine. Welcome to our November 2024 Grand Rounds. We're fortunate to have Lara Shefelbine, who is one of our R4s, and Elyse Brinkmann, who is one of our faculty who specializes both in orthopedic oncology and arthroplasty surgery, and they're going to be talking about Orthopaedics 2.0, the role of robotics in modern arthroplasty. It is a timely topic. We actually have a work group right now that is working with the administration on defining the needs for which robots we should invest in for our arthroplasty program and how many of them. So a very timely topic, and thank you. And I assume we are going to start with Dr. Shefelbine.
Correct. Let me just share my screen here. Thanks for the introduction, Dr. Chansky. Thanks everyone for being here, and thank you to Dr. Brinkmann for her portion of the presentation, which will be excellent. I have no disclosures. Just a disclaimer, there's a variety of products showcased just for demonstration purposes. Presenters don't endorse, and nobody is affiliated with any of these products. So just an outline. First, we'll go over the background of robotics and surgery and the history, specifically in hip and knee replacement. We'll go over some definitions of robotics and talk about the classification and types of systems available. We'll then move on to Dr. Brinkmann's talk on the current state of robotics in hip and knee arthroplasty. As we know, the goal of hip and knee arthroplasty is to reduce pain and enhance patient function of a diseased joint through a well-aligned and well-balanced joint. Reconstructive surgery has shown great success in returning people to prior level of function. In fact, in 2007, total hip arthroplasty was described as the operation of the 20th century. It consistently and reliably delivers clinically significant improvements in patient-reported outcome measures, according to this article. There have been many advancements in adult reconstructive surgery over the decades, including improving techniques, changes in approach, implant design, and material science. For instance, the introduction of highly cross-linked polyethylene liners as bearing surfaces, making these procedures even more reliable at improving patient quality of life. The question is, now that we've made such strides, how do we make it better? How do we improve outcomes? The reality is that hip and knee replacement are still far from perfect treatments. Despite the success of these surgeries and advancements in techniques, materials, and perioperative management, there are still significant risks and complications associated with these procedures. While total hip arthroplasty is one of the most successful surgeries available, still between 7 to 12% of patients are dissatisfied or uncertain about their outcomes. The most recent data suggests that by 25 years, up to 42% of total hip arthroplasties have been revised. Outcomes are even less predictable in total knee replacement, with dissatisfaction rates up to 20%. Rate of revision for instability following primary total knee ranges anywhere from 6 to 13%. Current survivorship for total knee arthroplasty, for all reasons, has been described as low as 60% in 20 years in some studies. All this to say that there is room for improvement to make procedures safer, more reliable, with improved patient outcomes. The question then becomes if technology is the answer to improving these surgeries. Advances in technology have made our daily lives easier, more efficient, and safer in many ways. It's inevitable to adopt some changes in most aspects of our lives. We don't want to still be using horses or first-generation cars as transportation. However, with every advance in technology comes new challenges, some of which may be unexpected. In healthcare, these may significantly impact providers, but more importantly, patients' lives. So how does robotics come into play? A robot is defined as a machine designed to carry out tasks automatically or with minimal human intervention. Funnily enough, this is a definition provided by ChatGPT. The Robot Institute of America defines a robot as a reprogrammable, multifunctional manipulator designed to move materials, parts, tools, or specialized devices through programmed motions for the performance of a variety of tasks. According to Mike Brady, who's one of the world's most respected robotics engineers, the field of robotics is the field concerned with the intelligent connection of perception to action, which to me was the most interesting and perhaps most pertinent definition of robotics. This definition is obviously broad, and in fact, most of us think of robots as humanoid machines. However, we do use robots in everyday life, such as washing machines, laser printers, elevators, and even traffic lights can be considered robotic. So, what is robotic surgery? Modern robotic surgery does not quite look like this, despite what many patients have in their minds when thinking about robotic surgery. Modern robotic surgery in orthopedics looks more like this, where a robotic arm, cutting jig, or navigation tools assist the surgeon, guiding through some of the steps of the procedure, such as making resection cuts on a total knee arthroplasty, as seen here. Robotics in orthopedics are a tool and offer the potential to improve total joint replacement surgery by enhancing a surgeon's ability to reproduce alignment and better restore normal kinematics. We'll go over different types and categories that exist currently, as well as the current data on how these affect patient outcomes. A brief history of surgical robotics. Robotic surgery dates back to the 1980s. So in 1985, the first robotic surgical system, which was called the Puma 560, was used in conjunction with CT during neurosurgical biopsies. Since then, the field has grown tremendously. In orthopedics, the first robot was introduced in 1992. This was the Robotics system, designed by a veterinarian and a medical doctor in Sacramento, California. This made history by being the first robot to be used clinically in orthopedic surgery. It was an image-based, active, autonomous milling robot designed to prepare the femoral side of a total hip arthroplasty in order to facilitate the use of cementless stems and improve bony ingrowth. That system underwent several developments and was approved for sale in the European Union, where it saw most of its popularity. During the 90s and early 2000s, these introductory systems underwent a series of lawsuits and scrutiny. However, this was also the decade where the most rapid development in these technologies occurred. The system underwent several developments and was ultimately approved for sale in the European Union, where it saw most of its popularity. In the 90s and 2000s, some of the introductory systems were subject to a series of lawsuits and scrutiny. In the United States, the Da Vinci surgical system was the first FDA-approved robotic surgical system and probably familiar to all of us. It's seen a wide variety of applications in general surgery, surgical oncology, gynecology, urology, with a lot of input and interest from the military and NASA as well. In orthopedics, the Mako system was the first orthopedic robotic system with FDA clearance, which was obtained in 2008. This utilizes a preoperative CT scan to better visualize the joint alignment and potential deformity before surgery. It allows implant position to be customized to patient anatomy. In contrast to the Da Vinci system, Mako virtually generates the final outcome, which is modified as desired and approved by the surgeon before an incision is made. In addition to the Mako system, there have been many other advances in orthopedic robots, and this ranges greatly. So what can robotic systems accomplish? In theory, a robotic surgery can be a tool to accomplish the following goals: executing a desired plan in a reproducible manner, achieving target alignment, individualizing a surgical procedure, such as for different patient anatomy or deformity, placing implants exactly where you want them to go, and for the surgeon, less energy expenditure. So where are we today with robotics and orthopedics? In technology management, every industry, from aviation to financial services, tends to follow 5 phases of development. Starting off, the industry is widely considered as an art by experts in the field, kind of contemplating any robotic intervention. Then there's the development of rules plus instruments to assist in goals. In the mid-range, there's development of standardized procedures and templates. And then moving forward to more involvement with technology becomes automation and computer integration. In aviation, for example, the first idea of a plane in the turn of the 20th century was viewed as an art and was futuristic only. However, today, thousands of airplanes fly every day, and there's been a massive increase in safety and cost effectiveness with the progression into phases 4 and 5, with autopilot systems, computer integration to process huge amounts of data points in order to have a smooth and safe flight in a very reproducible manner. The healthcare industry currently is probably around stage 3, and typically we know it advances much slower compared to many other industries. However, with integration of robotics and artificial intelligence, we may be on the cusp of entering stages 4 and 5. Now onto the classification of robotic platform types. There are different types of robots. In general, we classify them into passive, semi-active, or active. Passive systems complete a portion of the procedure under continuous and direct control of the surgeon. For an example, navigation. Semi-active systems require surgeon involvement, but provide feedback, usually tactile, to augment surgeon control. Examples include the Mako robot, in which you control a robotic arm that provides tactile feedback to guide the surgeon, as well as visual feedback on a screen. Active systems perform a task independent of any surgeon involvement. Currently, not many systems fall into this category. A unique aspect of robotics and orthopedics compared to robotics and other surgical specialties is the presence of a pre-approved plan to execute a procedure. In the case of robotic total joint replacement surgery, surgeon preoperatively or in real time plans the orientation and the sizes of desired implants. These plans can be performed either imageless, as is shown in this video, or image-based systems. In the case of imageless systems, the patient's anatomy must be registered via mapping points on the bone with a navigated tool. These are registered into a virtual model so the robot knows where it is in space in relation to the target. Advantages with this system include decreasing inconvenience of cost increase and no preoperative radiation exposure. However, disadvantages include the inability to verify anatomic registration points sometimes at the time of surgery. In the case of image-guided systems, the registration is directly tied to preoperative images in the form of CT or MRI, and implant positions can be planned based on these images. Disadvantages of this, there can be potentially the increased cost of preoperative imaging, as well as patient inconvenience to travel to obtain this imaging. So now there are many examples of robotics that fall into these categories, and they can be closed or open platform. Closed platform devices being only allowing one specific manufacturer's implant to be used, whereas open allow different implants and designs. One of the downsides of open systems, while they may have data on a number of implant types, they may lack the depth of design specificity to optimally predict kinematics or implant positioning. So the crux of the matter, the real question, can robots improve patient outcomes? Introducing robots into the orthopedic operating room may improve precision, may result in lower complication rates, and offer higher patient satisfaction scores. But ultimately, the acceptance of robotic surgery into common orthopedic practice will also depend on its cost effectiveness, particularly in the short term. Dr. Brinkmann will now present what the current literature shows and what the future of robotics in arthroplasty may look like.
But again, thank you, Lara, for that introduction. We're going to primarily be focusing on robotics in total knee, since that's where most of the literature exists right now, just to keep it focused since it is a big topic. I have no relevant disclosures for this talk. So going through the outline for my portion of the presentation, we'll look at market usage as well as marketing that's used in general for robotics and total joints, patient outcomes, and the differences between the robots as Lara described, utilization and training for residents and fellows, and then potential future directions for robotics and total knees. So in terms of current trends in market usage, I think this is important for everyone to be aware of. As Lara mentioned, there's a lot of interest in robotics, and it's certainly grown a lot over the last couple of decades. But it's important for us to understand what the overall market patterns look like. And there's increasing utilization of robotics in total hip and total knee arthroplasty. This is a recent report from the American Joint Replacement Registry. And this shows a threefold increase in use of robotic total joints since 2017. And the utilization of navigated total hip during that time has increased 40% since 2017. Now there's greater than 6% of elective primary total hips that are done using robotic assistance. Similarly, for total knee arthroplasty, there's been increased utilization over sixfold since 2017. And utilization of navigated total knee has meanwhile remained stable in contrast to total hip arthroplasty. And now greater than 13% of elective primary total knee replacements are done with robotic assistance. So why is this happening? It's probably in part related to marketing, and this may be patient-driven to some degree. So do our patients care about total joints? Yes, interest is increasing. I'm sure many of us who do arthroplasty, maybe even in other specialties too, you're asked by your patients about robotic joints or if we use robotics in some way in our practice. Our patients are interested, and in the modern digital age, our patients are very savvy with technology and demonstrate information-seeking behavior. They look us up ahead of time on LinkedIn, Doximity, etc., and often walk into their visits. They know where you trained, where you graduated, when you graduated, and they want to know if you're using technology too. And they're more and more interested in robotic total joints. The study from a different Dr. Brinkmann at Mayo, Arizona, no relation, observed that through Google Trends, the patient interest in robotic total joints, and specifically robotic knees more so than hips, is increasing at a significant exponential rate relative to the more linear increase in conventional total joints. It may be at least in part that patient demand is driving some of the increased utilization of robotics. Why do our patients care about robots? What are some of their assumptions and preconceived notions of what robotics offers for total joints? Lara alluded to this, and we'll go into what some of the survey studies seem to suggest that support that. So this is a study that was conducted with a 30-question survey of the public using Qualtrics, which uses participants of Amazon Mechanical Turk. It's an online platform where individuals or businesses can crowdsource virtual tasks, including surveys, to registered users, and they receive a small compensation for completion. 2/3 of the participants in this survey were 40 or younger, and 75% were familiar with the use of robotic assistance in orthopedic surgery. 1/3 had a clear preference for robotics over manual total knees. But importantly, most respondents believed that robotic-assisted total knee arthroplasty is associated with better results, fewer complications, less pain, and faster recovery. And it was somewhat evenly split with regards to a binary question as to whether they would favor a low-volume surgeon who used robotics over a high-volume surgeon who used manual techniques. Only half of respondents, though, actually understood the role of the robot in the operating room, in which the surgeon controls the robot and the instruments do the surgery. 23% believe that the robot has complete autonomy during the surgery. Primary concerns from patients, though, or at least the survey respondents that are related to robotics, are focused on surgeon experience and potential harm or complications related to use of the robot. Only 12% of respondents had concerns about the lack of research to support its use. And in summary, our patients are interested in robotics, but the understanding is not there, and they're relying on us to dispel some of the myths and claims related to robotics. And what do the patients see? So they're interested in this, but what are they seeing when they look this up online? It's on us to inform patients accurately, but are we doing a good job of that? As we mentioned, our patients are technology savvy and they're looking us up before their appointments. But what is the information that our colleagues are sharing? So this study attempted to answer that question, and they identified the top 5 largest US markets by population: New York City, LA, Chicago, Houston, and Phoenix. And simply Googled robotic total knee arthroplasty with the city and state. They excluded paid and company advertisements and took the top 10 hits in each city that mentioned robotic total knee and an orthopedic surgeon by name. And then they identified categories of claims made on these websites for advantages of robotic total joints. You can see some of the categories listed here that were identified, including increased precision or accuracy, being minimally invasive, rapid recovery, reduced injury to the tissues, increased implant longevity, less pain, improved outcomes or function, and less blood loss. But which of these claims are actually supported by at least some literature? And what do these websites look like? Specific companies were mentioned on 68% of the websites. 64% make claims reporting benefits of robotic total joints over conventional joints. 34% of surgeons had published on the robotic total knee arthroplasty themselves, but only 16% provided links or references to published literature supporting these claims, which is somewhat interesting considering more than twice had published on the topic. Are these articles not included because they show equivocal or negative results, or is this just simple oversight? If we just look at the total of number of articles alone that support or refute each of these claims, you'll see the only categories where volume of supportive literature is dominant is for increased precision and accuracy, reduced injury to the soft tissues, and less pain. This doesn't go into the quality of those studies, but there are at least more studies overall that do support this. And probably what's most alarming is the categories where there's only one or even no studies that can be found to support the reported claims, including claims that it's minimally invasive or imparts improved implant longevity or has less blood loss. And furthermore, there were 10 websites that were portrayed as personalized websites for a single surgeon, but that made identical claims with the same phrasing. And this suggests possibly an external third-party source that's creating these websites, which is concerning. course, we all want to outsource some of our non-clinical work as much as possible to reduce physician burden, but it's important to have appropriate oversight to ensure something like a public patient-facing physician website has accurate information. And moving on to the important stuff, what about patient outcomes? So in terms of looking at early revision rates, this is one of the big studies that's looking at, or most important studies that looks at this question, and it comes from the AJRR. It looks at Medicare-aged patients 65 and older with primary total knee that was done between 2017 and 2020. It was shortly after the widespread release of some of the major robotic platforms out there. There was a minimum of 2-year follow-up and 10% robotic utilization during this period. There was no difference between robotic and conventional total knee in odds of revision at 2 years during this time period, with a 1.2% rate of revision in both categories or both groups. The difference in midterm and long-term data is unknown in this study. There's increased rate of revision, though, however, that was noted for instability and pain in the robotic cohort. The increased rate of revision for instability is particularly surprising due to reported improvements in mechanical limb alignment and gap balancing with robotic-assisted techniques. So it's possible that robotic surgery may not limit the risk of these complications as previously hypothesized and reported in single surgeon studies. This may more accurately represent revision rates with the larger cohort that's represented in the registry data. With regards to late revision rates, unfortunately, there's not enough robotic systems that have been out to be able to look at this in a broad view. There's only one system that's been out long enough to have greater than 10-year follow-up, and that is captured in this study, which is a single surgeon prospective randomized controlled trial that compared robotic to conventional total knees in almost 1,000 patients in each group. There was a mean of 13 years of follow-up. This single surgeon study used the RoboDoc, and the surgeon used a PS knee with primarily unresurfaced patella, though there were 10 resurfaced at the very beginning in each group. All were cemented and all had a CT between 10 to 15 years post-op and a standing AP hip to ankle radiograph as well at each follow-up. In this study, there was an average of 28 minutes of longer operating time and an average of 37 minutes of longer tourniquet time. However, with regards to revision rates at 10 years, there were no differences, and there were also no differences in terms of radiographic outcomes, looking at limb alignment, component alignment, and aseptic loosening. However, when we look at this in a more granular level, there may be a higher incidence of radiographic outliers depending on the threshold for the definition of what an outlier is. If 3 degrees is used as a threshold with more strict criteria, there are fewer outliers in the robotic assisted group with, for example, 11% of total knees versus 20% in the robot versus manual group with respect to tibial coronal alignment that would count as outliers. But this difference is no longer significant if 5 degrees is used as the threshold. And importantly, these outliers did not correspond to higher rates of aseptic loosening or other revision. So despite increased precision, there was not a difference in the rate of revision. There was also no difference in functional outcome scores, along with survivorship or complications. And in this study, there was no report of pin site infection, pin tract infection, patellar dislocation, or fracture or other supracondylar fracture. Now, are all robot systems created equal? Not necessarily, and Lara did summarize this well in her talk. So these are the 5 main systems that exist. There is another that was more recently released, but there's much less data on it. So we'll focus on these. The Mako is the most commonly known system. This is an image-based system, which is semi-active and uses an oscillating saw. There is haptic feedback with a boundary control. The Navio or Cori system is imageless and uses a semi-active burr. The ROSA system can be used either in an imageless or image-based fashion. And this is more of a passive system where you place guides and then use a manual saw blade. The Omnibot is an imageless system with a guided manual saw blade. And then the T solution or RoboDoc is an image-based system with an active burr. So this is the only active system, as you'll see. The others are all either passive or semi-active. The RoboDoc was the first robotic total knee system that was available, and this is the only system that has long-term follow-up. But in the studies, as we mentioned before, or the main study that does look at long-term outcomes, there's no difference that's been seen in functional outcomes in either the short or long term. There are some reports of minor but significant improvement in radiologic outcomes with respect to implant and joint axis alignment. And the learning curve for this system has been reported to be 10 to 12 cases. Cases are typically 23 minutes longer on average, but it's important to note there is a wide distribution of bias in terms of studies with robotic total joints. This one actually happens to be less than some of the other systems. 17% of the studies for this system are industry funded. The Omnibot is one that was released later at the same time as two of the other systems. And there's no difference in KOOS scores that are relative to a cohort that's publicly available with a database of conventional total knees. The balance bot acts like a robotic laminar spreader to measure soft tissue tension throughout range of motion prior to any femoral resections with this system. And this is done after the tibial cut is made. So the tibial cut is performed first with this system. Use of their predictive balancing technique with the balance bot has been reported to improve the proportion of balanced knees, 88 versus 51%. And there were improved short-term functional outcomes at both 3 and 6 months, but with unclear clinical significance. And balanced knees were defined as a difference of less than or equal to 1.5 millimeters between either the extension and flexion gap or the medial and lateral gap. There is a paucity of literature with regards to data on complications, OR time, or the learning curve, and a majority of studies for this system were industry funded or had some other potential conflict. The Mako is one of the most widely used and known systems. This was also released for total knees in 2017 and is a semi-active system with an image-guided haptic feedback saw. This too showed improved radiographic outcomes, but there's been no correlation with improved clinical outcomes. The learning curve has a wider range from 7 to 43 cases, and setup, which is prior to incision, is reported to be 9.2 minutes when optimized. Unfortunately, the long-term revision rates, again, are unknown, and 50% of studies with this system have had potential conflict. The reported learning curve does seem to be larger because there are more studies available, which may better reflect the diversity of the population who's using this system. The Cori or Navio, these are both with Smith & Nephew. The Cori is the successor to the Navio, and this is a semi-active imageless burr system with the learning curve reported to be 7 to 11 cases. There are some studies reporting possible increased surgical time with use of this device compared to conventional total knees. Again, revision rates are unknown and bias is prevalent. The ROSA is another closed platform system, which can be used as an image-based or imageless system with a guided manual saw blade. So this is a passive robot involvement to place the guide appropriately. There is only one recent study that met criteria for inclusion in the systematic review. And similarly, the learning curve is reported at 6 to 11 cases with an 18-minute increase in length of the case. So overall, most studies evaluating improved surgical precision did use the principle of neutral mechanical alignment as the target, which is important to keep in mind, and particularly in the RoboDoc studies. But the improved precision with the robot And reduction in outliers may increase its ability to be used for other individualized alignment techniques like kinematic alignment, though that's outside of the scope of discussion for today. There are a few studies with different robot systems that have reported short-term improvements in functional outcomes, but these are likely typically small differences which are not meaningful clinically. There may be potential for improved soft tissue tensioning during the surgery, and this represents some of the potentially useful data that we can capture more easily with total joints or with robotic total joints. Soft tissue tensioning during surgery can be evaluated in one of three ways when using the robotic system. And the first way, the surgeon exerts a varus and valgus force on the knee with or without a tensioner. But this depends on several factors, including surgeon strength, depth of anesthesia, BMI, and physical stature of the patient. So even though there are some objective gap balancing values that are reported, there is still a component that is subjective with this. Another way to assess balancing would be with sensor-guided technology. This does exist with the Mako system, for example, in the form of a disposable device in the tibial insert for more objective ligament balancing during the case. And then, as we mentioned, the balance bot with the OmniBot allows for standardized distraction of the joint throughout range of motion. But this does require a technique in which the tibia is cut first. Other potential advantages may be improvements to supply chain efficiency, particularly with the image-based systems where imaging is obtained prior to surgery, and we therefore may be able to do more accurate templating. So this could improve efficiency with materials management, implant distribution, etc. Anecdotally, there's some surgeons who do high volume robotic total knees, and they report bringing only one femoral and tibial implant size into the operating room once they get to their highest level of efficiency. And then they have various poly sizes available. As far as potential disadvantages with robotic knees, of course, as with any new technology, there is a learning curve. This isn't publicly or published for all systems, and it's reported to have a wider variation with Mako as mentioned, but again, there are more studies available for the Mako system. So this may just be a better representation of what that learning curve could look like in different hospital settings and practice settings. And it's important to understand that this increased learning curve is in reference to the surgical workflow and length of the procedure, but not related to implant alignment accuracy. In fact, there's no learning curve that's been reported with this in most studies. Accurate implant positioning is typically achieved with the first case in which the robotic system is used. And recall, there's certainly a high potential for conflict with the available studies for robotics, and many high-volume surgeons involved in the design process published some of the single surgeon reports on the short learning curve. So this may not be widely generalizable data. This also changes the workflow for staff as well. And certainly without consistent OR teams and staff, this learning curve could be expected to be prolonged. Increased surgical time is also reported with the use of robotic knees, and in general, we associate increased operative time with risk of infection, though in the data that's available, there have not been differences in infection that have been reported between robotic and conventional total knees. There's also setup time that's required prior to incision for robotic joints, which could impact OR efficiency. And robots are not small, and in general, they have at least 2 or more separate large components between the robotic arm or end effector and the screen, in addition to the arrays and other components on the back table. With this OR space utilized, this can potentially increase the risk of contamination of the sterile field and can limit available room for assistants or trainees. And when it comes to long-term outcomes, the RoboDoc is the only system that has long-term studies available greater than 10 years, but there is no difference in revision rates. The complication rates are not reported consistently, but there are no clear differences in complication rates as well. But it's important to be aware of the unique complication of periprosthetic fracture through pin sites for tracking arrays, though this is rare. One study has reported it at up to 5%. Radiation also is used for image-guided platforms in which CT is obtained prior to surgery, and it should be considered with both cost as well as exposure of radiation to the patient. And with the exception of one system, most of these platforms most of these robotic systems are largely closed platforms that are implant specific. So this does restrict surgeons and hospitals in terms of implant options and implant design. The design specificity may allow for improved functionality and accuracy relative to an open platform system, but there are significant limitations that this imparts on the surgeon and hospital. And also, of course, cost is a concern. This can be different hospital to hospital based on contracts, but there's typically a large upfront cost primarily, as well as potential added cost per case with additional imaging like CT scans. But as mentioned, there's no clear difference between no clear difference in long-term clinical outcomes or complication rates, and there's no clear differences between robots as well. There are some meaningful differences between systems beyond the implant design themselves for these closed platform systems. So some have suggested we shouldn't just use the term robotics in the literature to avoid inappropriately lumping these very different systems together. But that being said, we're unable to assess meaningful differences between patients through a meta-analysis, since these patient-reported outcomes and functional outcomes are reported with too much heterogeneity. So how can we use robots in training practice in a residency program? Some of the systems have mobile applications that are available, which you can use at leisure to simulate intraoperative balancing and to help with the decision tree. So this may be a potential benefit for use with resident training. Also, there's intraoperative feedback that's available to trainees with use of robots. This is facilitated by the accurate bone resection, gap balancing, and mechanical alignment. In particular, semi-active systems with haptic feedback do have mechanisms to constrain the borders of the saw or the burr and can help provide feedback on appropriate spatial positioning relative to patient anatomy. You can also do real-time evaluation of gap balancing by seeing how changes in component positioning can affect your gaps, medial or lateral, or with flexion and extension. And there's potential that it could be safer as well. And some people do argue this. Haptic boundaries can help provide soft tissue protection, but not to all structures. It does provide protection to the MCL, as well as to the posterior neurovascular structures and the posterolateral corner. But importantly, it does not provide any protection for the patellar tendon. And of course, the robots cannot, as of yet, be used for patellar cuts as well. This is always going to be a freehand or other type of guided cut. What are some drawbacks with regards to use of robots with resident training? Well, of course, this still does not replace the acquisition of skill needed for manual total knees. You have to be able to troubleshoot if the technology is not functioning or is not available, or in case of a complication. And overexposure could potentially be a detriment to the number of cases that are done with manual total knee techniques, and therefore manual total knee education. And then there's a question of whether this increases operative time or not. Well, a few studies have attempted to answer some of these questions or look at some of these potential myths. In particular, this was a survey of North American orthopedic surgery resident program graduates completed a couple of years ago during a national board review course. Most attendees did respond to the survey. 24% that responded planned to complete an arthroplasty fellowship, and 60% of respondents, regardless of their plans for fellowship, anticipated performing total knee, unis, or both in practice. 70% had been exposed to robotic total knees during training. 22% reported that over 50% of the total knees they did were robotic, and 39% in general were exposed to a robotic uni compartmental knee arthroplasty. Higher robot case volume and percentage during residency training were associated with a change in the belief of what they thought that robots could offer total joints. And one of those things was a belief that robots improved their understanding of the surgical procedure, but it also did reduce comfort with manual total knees, particularly in those who completed 50 or 75% or more of their cases with robotics over manual knees. There is also a greater belief that robotic assistance improved patient outcomes, and a lesser belief that robotic assistance was used for marketing purposes or improved patient safety. 37% of respondees agreed or strongly agreed that they wished their training program offered more robotic total knee experience. And as mentioned, there is a learning curve to adopting any new technique or technology. And so this study attempted to look at how that happens. And this was particularly looking at the Mako. This was one of the ones on the lower end of that trend that found a 7-case learning curve to achieve consistent operating times. But as mentioned prior, implant positioning and accuracy was achieved immediately. And this learning curve should be taken into consideration for potential faculty who are learning how to use the technology as well. So when training residents to use robotics with total knee arthroplasty during residency, one program did attempt to answer this question as to whether it does increase the length of surgery or not. And this was completed looking at 110 consecutive patients that were done before and after initiation of the robotic assisted technology, but this did exclude the first 10 cases that were done by the faculty member alone to allow for that learning curve mentioned prior. So it was a single surgeon with 10 different trainees ranging in level from a second year to a PGY 6 or a fellow, with 3 consecutive months with each trainee. The surgeon did perform some cases with a PA only as an assistant or with a trainee as an assistant during the case, and compared operative times for each. And keeping in mind that with a resident or trainee, the expectation would be to graduate responsibility, whereas with a PA or other APP, the surgeon or faculty member would be doing the entirety of the case for the duration. There was a longer tourniquet time overall with robotic total knees with 99 versus 88 minutes on average, and that was significant. But this longer tourniquet time was present regardless of whether it was a trainee or a PA as a first assistant, and there was no difference between those groups. So as far as future directions with robotic total knee arthroplasty, it's important to know what questions are still unanswered. One thing we still haven't answered yet, though, is certainly of interest in the literature, is its utility in revision total knee arthroplasty. Also, we have yet to demonstrate meaningful differences in long-term outcomes, even though we do see increased accuracy. Also, we are more accurate, but we don't know what that target should be. So what is our target joint alignment, and what's our objective soft tissue tensioning that we should be targeting as well? And as we know, the cost of robotics is certainly high, and we need to have appropriate justification for the cost. So in summary, there are many different types of robotic assistance that are available for use in total joint arthroplasty, both imageless or image guided. And then the other 3 types overall or categories would be active or semi-active or passive systems. We have demonstrated improved precision and accuracy with robotics. We get the results that we intend with our pre-op plan, but we don't yet have proven long-term outcomes yet to justify the cost or to demonstrate improvement in outcomes related to that increased accuracy and precision. But we can at least likely say with the data that there's non-inferiority with use of robots. And we need to understand what that target is. We're accurate, but we need to know what the appropriate target should be. Patients are also expecting us to increase the use of technology and robotic systems, and this may be in part what's driving the market along with industry. But we need to be in control of the way that information is being distributed, and we need to ensure that accurate information is being distributed to our patients. And then, of course, residents and trainees expect exposure to robotics. It seems to be safe and it may enhance training, but of course, we need to keep in mind that it cannot come at a sacrifice of exposure to manual treatment. Thank you, and I'm happy to answer any questions.
People should feel free to either put a question in the chat box, raise your virtual hand, or also just you're welcome to just speak up. Thank you for that, Dr. Shefelbine and Dr. Brinkmann. It was an incredibly thorough overview. I'm wondering if any of our arthroplasty surgeons that are watching Grand Rounds have any comments. Dr. Manna or Dr. Fernando. I don't know if Dr. Hernandez is on the call.
Yeah, this is Paul here. Yeah, I thought this was a really nice overview of the topic. I mean, it's something that we get every day in clinic with new patients, you know, where they're asking, you know, oh, do you use a robot? And, you know, you have to sort of go through a little bit of this. And, you know, I think it is important to point out that for things that matter to patients, which are pain, function, alignment, stability, there's no evidence at all that a robot makes any difference at all, whether it's a hip or it's a knee. You know, I find it, you know, I do find it a little surprising that alignment seems to matter so little, but you know, there's some pretty good studies that out of the Mayo in particular that show that, you know, there's about a 3-degree bit of slop that you can accept before, you know, things start to go south in terms of alignment. You know, things that a robot can do, things that computer navigation can do are reduce the number of outliers. But, you know, what seems to be the case is that although that matters to us, you know, we don't like to look at x-rays that don't look very nice, but it doesn't seem to matter much to a patient, you know. And again, you know, I think it's one of these things that it makes sense to keep playing with it and keep looking at it and, you know, seeing if there is something that we can do to make this better. But it's also something that patients need to understand that this is not a magic bullet, that it does not change how the knee feels. It does not change how the knee functions, does not change, you know, its range of motion. And if they're kind of expecting, you know, this major, you know, wonderful improvement, they are going to be disappointed.
Yeah, and I think that summarizes it well. Yeah, we're definitely more accurate, but I don't think we've proven that it's changed outcomes. It may just be that we're too early in terms of the data that we have available. There's, you know, the few short-term studies that suggest possible benefit, but there's certainly a lot of bias in the literature with this topic, unfortunately. But yeah, we don't, you know, that RoboDoc system isn't very widely used anymore, and that's the only one that we have true long-term outcomes with at this point that are over 10 years. But I think we can get more data from this that we can use going forward, since we do have more accuracy and more objective points that we can collect with robotics that can hopefully help us figure out what that target is.
Yeah, when we're
To our,
discussing this
oh, I'm sorry.
oops, sorry.
No, go ahead, Dr. Mattson.
When we're discussing the shoulder world, we, like you all are nicely doing, distinguish accuracy from precision from clinical significance. And sometimes when we're explaining this to patients, we use the goalpost analogy, which is you get the same number of points kicking a field goal if the ball goes exactly down the middle of the goalpost as it goes a few feet to the left or the right. It doesn't really matter. And that's sort of like the clinical significance thing that you were just bringing up, Elyse and Paul. But then there's a boundary beyond which it really does matter. And that's when the ball goes either to the left or the right of the goalpost. So sometimes that's helpful because I think in our field, people are really fixated on accuracy and precision, but sort of forget the clinical significance part of it.
Yeah, to our credit, as we've talked about robotics for total joints over the last, I would say, 15 years, we've always adhered to the evidence, and we've not pushed the administration to get these systems for us. But I think what Elyse mentioned in terms of marketing, resident education, hopefully we will have a total joint fellowship again at some point. And I think it's become clear to all of us that we really can't effectively compete without having robotic systems to offer some of our more educated patients in the area, even though we spend quite a bit of time in clinic explaining to them what Dr. Matson just talked about. But I think there are compelling reasons for us to now start pushing to have a couple of these in place for training, for marketing, for being able to offer it to patients who insist that they need it. The other thing I'd add is that I think Dr. Brinkmann mentioned it in one of her slides, but I suspect we've all had the experience of seeing the greatest outliers come to our practices for second opinions or revisions after having robotic surgery. I know I've certainly seen some incredible disasters that I don't think would have been produced by somebody that was using their brains and hands for the entire case. So I think in at least during that learning curve, there might be a tendency to really produce some significant outliers. And I recall even recently a patient that was referred to Northwest Hospital, if I recall, an 80-something woman who remember they had knocked the anterior third of her femur, and within a couple of days post-op, she had a periprosthetic fracture and needed a distal femoral replacement. So certainly the robotic systems aren't perfect, but I do think there are some compelling reasons for us to get them. And also, hopefully we could use them and study them and define, how they're going to be used in the future, and perhaps we can even work on improving the technology. Navin, do you have any comments?
I don't know if you can hear me, I'm driving, but I suppose
Are
I
you
would echo
driving a
everything
robotic car and you're not going to have an accident while
well,
you're
I'm not,
talking?
but I suppose to that point, automation and technology and AI and I think evolutions in this field. I'm not familiar of a field of industry in which is precision dependent, although that's a broad definition, that hasn't been assisted or improved with robotic technology. Even a quartz watch is more precise than a automatic. So if that's considered of relevance, then I think we need to be involved in this field. And I think again the outcome studies that have been done, although relatively robust, probably don't have tools that are fine enough or granular enough to distinguish some of these potential improvements. So it's still a very early field of study, and like I said, I think we need to be involved in this in order to be relevant.
Hey, this is Viral. So we started using the spine robot now, and after using many years of hand, like by hand under CM X-ray navigation, and now a robot putting a pedicle screws. So my PA L, he was scrubbing with me for last 1 or 2 years, and when he started using a robot, so he told me one thing, and then he basically told me this basically makes accurate surgery more accurate. So that's the thing I'm using it now with the patients until proved otherwise, that this makes accurate surgery more accurate without any difference in the patient's outcome at this point, when patient asks me.
Howard, I know that you're interested in departmental history. I put in the chat a reference from 30 years ago regarding some early attempts by your department to use robotic assistance in total knee arthroplasty. I thought you might be interested in that.
Yeah, Rick, you're cutting out, and I see now in the chat, and I've clicked on the link. There, Dr. Matson had done in the 90s, and I'd ask everybody to take a peek at that. And there's also a comment by Dr. Yang on the remarkable success rate for total knee replacement. And I would agree. There are some studies done by physicians and economists that suggest that there's no bigger bang for the buck in all of medicine than total hip replacements and total knee replacements.
Rehab.
Well, I don't see any other hands up, and so thank you again to Dr. Shefelbine for stepping in. I suspect at the last minute and doing a great job for Dr. Prieto, and then also for Dr. Brinkmann for a remarkably thorough overview of this technology. Don't forget, everybody, to text for your CME credits within, I think, the next hour. And I hope everybody has a great day and a great week. Thank you.
Thank you.
Thanks, everyone.